Hello and good afternoon, everyone. I, Dr. Nayara Faruqi, welcome you all to Physio TV. Today we are in the part 2 of PNF in Neurorehabilitation by Dr. Dinesh Chavhan sir. I would like to welcome you, Dinesh Chavhan sir, and hand over the session to you. Thank you.
Thank you, Nayara. Okay, so PNF in neural rehabilitation part 2. So here we are going to study objectives. We'll see today what are the patterns, what are the technique used in PNF, and what are the uses of PNF. And we'll see what are the recent advances. Pattern will see upper limb pattern, lower limb pattern. So upper limb pattern, D1 flexion. So what are the component in a D1 flexion? We'll see for the upper limb, at the shoulder joint, at the elbow joint, and wrist joint and the finger. So D1 flexion, shoulder joint, flexion of the shoulder, adduction of the shoulder, and external rotation of the shoulder. At the elbow, flexion or extension depend on the short arc or large arc movement. Forearm will see supination, wrist radial deviation and flexion, and finger flexion and adduction of the finger. So in D1 flexion, we saw shoulder, elbow, forearm, wrist and finger movement. D2 flexion of upper limb. So what movement occurs at the shoulder? At the shoulder, flexion, abduction, external rotation. At the elbow, flexion and extension, depend or extension. At the forearm, supination. At the wrist, radial deviation and extension. At the finger, extension and abduction. What are the movement happens during a D2 extension of the upper limb? So at the shoulder, extension, adduction, internal rotation. At the elbow, flexion or extension. At the forearm, we see pronation. At the wrist, ulnar deviation and flexion. At the finger, flexion and adduction. So during D1 extension, shoulder extension, abduction, internal rotation. At the elbow, flexion or extension. At the forearm, pronation. At the wrist, ulnar deviation and extension. At the finger, extension and abduction. So when we want to perform a D1 flexion of the upper limb, we have to start from D1 extension of the upper limb. So we should know what are the D1 extension movement. So starting position will be a D1 extension for D1 flexion and ending movement will be a D1 flexion. And same happens with the D2 flexion. So we want D2 flexion. So we have to start from D2 extension. So D2 extension, we should know what is the movement occurring at the shoulder, elbow, forearm, wrist and finger. So that will be our starting position. So what is the ending position? To attain the D2 flexion, we should know what the movement happening at the shoulder joint, what movement happening at the elbow joint, forearm, wrist joint and the fingers. So we'll see the small videos of D1 flexion. Patient model in a supine line position.
We'll see D1 flexion of upper limb PNF pattern. So initial position is D1 extension. Okay. So in the D1 extension, abduction, interrotation of the shoulder, extension of the elbow, pronation, forearm, wrist extension, finger extension. Now hold my hand, yes, press, hold, yes. It's the flexion of the wrist. I'll give a traction and touch to the opposite ear, touch to the opposite ear, touch to the opposite ear, take it, yes. This is the ending position. So what is happening? Flexion, adduction, external rotation at the shoulder, flexion at the elbow, supination at the forearm, and flexion of the wrist and flexion of the finger. It's the ending position.
Yes. So as we saw D1 flexion, if you want to attain a D1 flexion of upper limb, the starting position will be a D1 extension of the upper limb. So when we are giving a D1 flexion pattern, so we should start from D1 extension pattern. So when we see the movement, the total pattern, the therapist movement in the plane of the movement. So now we'll see D1 extension of upper limb. So in D1 extension of upper limb, we'll start with the D1 flexion of
extension of upper limb PNF pattern. So initial position
upper
is
limb.
D1 flexion. So initial position, flexion of the shoulder, adduction, external rotation. Okay. Elbow flexion, wrist is in flex position, and supination of the forearm and finger is flex. So this is the initial position. So now open, finger, open. Yes, distally extension of the finger, extension of the wrist. Now I'll give a traction. Touch to the opposite coast. Touch, take down, take down. Yes, this is the ending position. So D1 extension. What is happening? Extension, abduction, internal rotation, elbow extension, pronation of forearm, and wrist extension, finger extension. This is the ending position.
Okay, so we saw the D1 extension of upper limb. So D1 extension of upper limb has started from D1 flexion of upper limb. So we saw how the movement is performed from D1 flexion to D1 extension of the upper limb. So movement at the shoulder, abduction, extension, and internal rotation, elbow extension, forearm pronation, wrist extension, finger extension. Now we'll see D2 flexion of upper limb. So it will start from D1. D2 flexion of upper limb will start from D2 extension of upper limb.
Now we will see D2 flexion of upper limb PNA pattern. So initial position is D2 extension. So this is the D2 extension position. Shoulder adduction, extension, internal rotation, elbow extension, pronation of the forearm, wrist flexion, finger flexion. Now open. Yes, hold that position. Yeah, hold that position. So here extension of finger, extension of the wrist. I'll give a traction. Yes, take up. Yeah, this is the end position. So what happening in D2 flexion, external rotation, and abduction at the shoulder. Elbow extension, supination of the forearm, wrist extension, finger extension. This is the end position.
Okay, so D2 flexion movement, if you want upper limb, it has to start from D2 extension, the starting position, and D2 flexion is the ending position as we saw in the video. Now we'll see D2 extension of upper.
So now we'll see D2 extension of upper limb. Okay, so initial position is D2 flexion. So what happening in the flexion? Flexion of the shoulder, abduction, external rotation of the shoulder, elbow extension, supination of forearm, extension of finger, extension of wrist. So now hold my hand. That is flexion. Okay, hold my hand. I give a traction and touch to the opposite edge, touch, down, good. So end position is what? Extension, adduction, internal rotation of the shoulder, elbow extension, pronation of the forearm, flexion of the wrist, flexion of the finger. This is the initial, position.
So, okay, we have saw the D2 extension of the upper limb. So it has to start from D2 flexion of the upper limb. So now we'll see the lower limb pattern. So what are the lower limb pattern of D1 flexion, D1 extension, D2 flexion, D2 extension of the upper limb? So what are the component and movement happening at each joint? So at the hip joint, we see flexion, adduction, external rotation. At the knee joint, flexion or extension. At the ankle, dorsiflexion. And at the foot, inversion. So these are the movement we see during D1 flexion at the hip, knee, ankle, and foot. So if you see for D2 flexion, the hip flexion, abduction, internal rotation, at the knee joint, flexion or extension, at the ankle joint, dorsiflexion, and at the foot, eversion. Okay, if you look at the both D1 flexion and D2 flexion, the foot plays important role. D1 flexion, inversion, D2 eversion. But both what happening at the ankle similarly is dorsiflexion. What happening at the D2 extension during? So at the hip joint, extension, adduction, external rotation, at the knee joint, flexion or extension, at the ankle joint, plantar flexion, and the foot, inversion. If you see D1 extension at the hip joint, extension, abduction, internal rotation, at the knee joint, flexion or extension, at the ankle joint, plantar flexion, and the foot, eversion. So if you look at how to remember with respect to the foot, in a flexion, the ankle movement will be a dorsiflexion for both, but only in a flexion we'll see inversion, and in D2 we'll see eversion. Same happens with the extension. If you see at the ankle, both are plantar flexion. The difference is in D2 extension, inversion, D1 extension, eversion. And if you see diagonally from D1 flexion to D1 extension, at the foot exactly the opposite. Dorsiflexion in D1 flexion at the ankle, and inversion if you see at the D1 extension at the ankle, plantar flexion, and foot eversion. Again exactly opposite, like in the D1 here, D2 flexion and D2 extension. At the ankle joint, dorsiflexion, eversion. If you see here D2 extension, at the ankle joint, plantar flexion, eversion. So these are the things smallly, if you look at it, it is very easy to remember that the flexion, dorsiflexion, eversion, eversion. At the extension, D1, D2 extension, plantar flexion at the ankle. Only the difference is inversion and eversion. Now we'll see how it perform on the model. We'll see a small videos of each pattern. So D1 flexion of lower limb.
So now we'll see D1 flexion of lower limb, okay, PNF pattern. So here first position, initial position is D1 extension of lower limb. So what happening in D1 extension? Abduction, extension, relative, and internal rotation, okay. So from here knee extended, plantar flexion, and eversion. So now here we'll start, okay, hold the position, dorsal of the foot, yes, thigh, lower knee. Try to touch your heel to the opposite knee, okay. Yeah, you have to do little traction, take up, try touch, yeah. So end position is what happening? Flexion, adduction, external rotation of the hip, knee flexion, dorsal flexion of the foot, and inversion.
So as we saw in the video, the starting position of D1 flexion was D1 extension and the ending position was D1 flexion. So how to facilitate, where to grab with a facilitation at the ankle and the knee, we have already saw in the videos. Now we'll see D1 extension of lower limb. So it will start from D1 flexion of lower limb, the initial position. The ending position will be a D1 extension of lower limb. Now we'll see the videos of how to perform.
Now we'll see the D1 extension of lower limb PNF pattern. So initial position is D1 flexion. So this is the initial position. So initial position, flexion, adduction, external rotation at the hip, knee flexion, dorsiflexion and inversion. So now from here distal to proximal movement, yeah, push on my hand, push my hand, yes, this is the, yes, push me out, push me out, push me out, push me out, quick, relax. Okay, so this is the end position D1 extension. What happening? Extension, abduction, internal rotation of the hip, knee extension, foot, plantar flexion and everge.
Okay. So we saw the D1 extension of lower limb is starting from a D1 extension of D1 flexion of lower limb. So starting position. Now we'll see the D2. So D2 flexion of lower limb. So the starting position will be a D2 extension of lower limb. So now we'll see how it will perform on the model or patient.
Now we'll see D2 flexion of lower limb PNF pattern. So initial position is D2 extension of lower limb. So D2 extension, adduction, external rotation at the hip, knee extension, plantar flexion and inversion. So this is the initial position. So dorsum of the foot, you have to keep the hand, yes. Take up, yes. Dorsiflexion and eversion, lower thigh, push me out, push here. This is the ending position. So what happening here? Flexion, abduction, internal rotation at the hip, knee flexion, dorsiflexion and eversion.
Yes. So we saw the initial position and the ending position of the D2 flexion. So now we'll see D2 extension. The starting position will be from D2 flexion. So now we'll see how to perform D2 extension.
Now we will see D2 extension of lower limb PNF pattern. So initial position is D2 flexion of lower limb. So what happening in D2 flexion, abduction, internal rotation at the hip, knee flexion, dorsiflexion and eversion. Okay, so now I put plantar aspect the hand and lower thigh. Okay, now what you have to do, touch your heel to the opposite heel. Okay, down, good. So this is the end position. So what happening? Adduction, extension, external rotation at the hip, knee extension, plantar flexion and inversion on the foot. Okay.
Okay, so D2 extension of lower limb, we have to start from the D2 flexion of the lower limb. So with this, we have done with our pattern. We have discussed the pattern with the reasoning and with the video. So now we'll move on the techniques. So what are the techniques used in PNF? So there are technique of facilitation, there are technique of inhibition, there are technique of stability to improve. So facilitation technique, rhythmic initiation, dynamic reversal, combination of isotomy, repeated contraction. So rhythmic initiation says that whenever we do any movement, it has to be in a rhythm. So initiation, the name itself says that the movement, we have to initiate the movement. So when we want to initiate the movement, when there is a loss of power or no control, so there we have to start with the passive movement. So passive movement can be a pattern. So initially we have to teach the movement to the patient passively. As learn the patient movement passively and they develop a little bit control, and then we start with the assisted. So that means active assisted movement. So active, after performing active assisted movement, we start with the registered movement in a small range. So as we increase range, so we go from active assisted to registered, and we use a resistance, and if we achieve a complete range by giving in a small range resistance, we go for an active range of motion. So rhythmic initiation can be used in those patient or those condition where the mobility is the problem, where the initiation is the problem. So in that condition, we use a rhythmic initiation. When we want to tease the movement, so that time we use a rhythmic initiation. Start from passive, active assisted, resisted, and the active movement. So next is combination of isotonic. In a combination of isotonic, the same muscle, the name itself says that movement will be isotonic. Combination is a combined movement. So whenever we want to do any movement or any task or any activity, sometimes we required the same muscle has to work eccentrically, same muscle has to work after some time concentrically, and in between the muscle has to hold, that is isometrical. So when the same muscle work as eccentrically, concentrically, and with this the contraction, static contraction, we can call it as a. So when all three movement is happening, eccentrically, concentrically, and static contraction of the muscle, it is called as combination of isotonic. So mostly this use in both those muscle like postural muscle. We want a small range of motion with a control movement. So there we want to use a combination of isotonic technique. Next is dynamic reversal. So dynamic reversal, the name itself says that dynamic means that it has to be a continuous movement. Reversal means when the agonist is working, so after next time the antagonist work as a agonist. So movement will be a reversible. Movement will be a continue dynamically. So when we want one group of muscle to act, other time other group of muscle will act. So here we'll see continuous movement, reversal movement, dynamic movement. So this is called as both the muscle is working. One time is agonist working as a and after the some time antagonist is working as an agonist like. So dynamic reversal is continuing both the group of muscle is working. Next is repeated contraction. So repeated contraction will be like we have to provide a little stretch. If we provide a little stretch, the continuously give a little stretch and do the movement. Give a little stretch and do the movement. So when we do repeated contract, the same muscle will contract and relax after some time. Same muscle will contract and relax. So here we are focusing on the agonist muscle. So these are the facilitatory technique used in PNF approach. So now we'll see how the combination of muscle, a combination of isotonic used for the trunk muscle.
Slow, come down, slow, maintain, slow, come down, hold, good, hold, 1, 2, 3, 4, 5, back, good, good, come down, good, hold, go back.
Yes, so here, if you see, this is the patient of spinal cord injury who has a fair trunk control. We want to improve the trunk control. So when I ask patient to bend forward, so when patient is bending forward with a control movement, the back extensor will activate eccentrically. What is the eccentrical definition of the muscle contraction is movement has to be towards gravity. It has to be a control movement and the muscle has to lengthen. So when we perform the movement forward bending, back forward bending, the back muscle is working eccentrically because the movement is happening towards gravity, muscle is lengthening and it is controlled back. So this is for back extensor muscle. So when the patient is coming back, that time the muscle is working concentrically because against gravity movement and there is a contraction. This is called as, and if I in between I told the patient that hold that movement, that means a static contraction. So combination of isotonic, we use the all three type of muscle contraction for the same muscle. Now we'll see for the other group of muscle.
Go back, maintain control, go back, control, hold that position, slow, 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 good, hold, come back, come, yeah, good. Good. Yeah. Go down slowly, maintain that slow, go slow, very good, slow, come up, come up.
So if you see in the sitting position, I have asked patient to go back with the control movement. So whenever leaning backward, that time your abdominal muscle is working eccentrically because the movement is happening towards gravity. And I told him that do a slowly movement. And if you see slow movement towards gravity movement and the abdominal muscle is lengthening, that is eccentric type of muscle contraction. And in between, I told him that hold that position. And after some time, I've asked patient to come back. So whenever he's coming back or coming western, so type of muscle contraction changes. That is muscle contraction is your concentric type of muscle contraction. So if you see in a one movement, three type of muscle contraction: eccentric muscle contraction, concentric muscle contraction, and static contraction of muscle. So this is called as combination of isotonic movement to the abdominal muscle. Now we'll see repeated contraction. So we'll give a quick stretch to the patient.
Up. Push me down. Push me up. Good. Push me down. Push me up. Push me down. Up. Good. Down. Push up. Down,
So here a contraction. So here I give a quick stretch and ask patient to lift up. So contraction of agonist muscle. I give a quick stretch and ask patient to push down me. So contraction of again the opposite group of muscle. That means repeated contraction is given stretch to the muscle will activate. That is a repeated contraction, which is very good for a breathing to activate hip extensor muscle. Now we'll see rhythmic initiation.
Bend. Bend. Take up. Take up. Take up. Very good. Take up.
So if you see here, initially I start with the passive movement. So first I again facilitate in the pattern passive movement. Then I ask patient to perform active assisted movement. So here we use both passive plus active. As patient improve the strength of the muscle, that it will goes to the active assisted to the registered to the whole range in the active movement. So this is the rhythmic initiation we use in a pattern. So now we'll see what are the stability technique. So mostly stability technique we use for a trunk muscle because these are the postural muscle. These are the muscle used for a stability. Trunk muscle to attain that position, to maintain that position so that the limb, upper limb, lower limb mobility will be a good. So we have to provide this technique. This is rhythmic stabilization, stabilizing reversal. So what is the definition of rhythmic stabilization? So rhythmic stabilization is where both agonist and antagonist working together to maintain that position without the relaxation or without changing the movement or hand position of the therapist. That is nothing but rhythmic stabilization to maintain that stability. What is the difference between stabilizing reversal? Stabilizing reversal is nothing but we change the hand. So activation of the muscle, again, the main aim is to provide the stability. But here, if agonist is working, antagonist is a little bit relaxing, then we have to change the position. So here, changing the hand placement, we change the activation of muscle. So we'll see now how it perform on the patient.
Push me forward, push me backward, push, ढकल, मागे, very good, hold, 1, 2, 3, 4, 5, relax. One more time, push forward, push backward, maintain, there, 1, 2, 3.
So here to improve the trunk, I use both rhythmic stabilization, both the hand to maintain the position in a sitting. So I given the register and ask the patient to maintain that position, don't move, stay there. I was providing the resistance in anterior direction and posterior direction. So there they have to attain that position to improve the stability by activating a anterior group of muscle, posterior group of muscle to providing a stability to the joint. So rhythmic stabilization, this is helps to provide a stabilization to the improve a stability or push. So how to perform in sideline also. So we can perform is in sideline also.
So तुला काय करायचं इकडनं पुढे ढकलायचं आहे इकडनं माग ओके पुश यस मेंटेन दॅट पोझिशन होल्ड पकड होल्ड 1 2 3 4 5 रिलॅक्स push me forward push me backward maintain that position 1 2 3 4 5
Okay, so those patient is not able to sit independently. We can provide, we can improve this trunk stability. We can give in a sideline also this technique. We can use this technique so that if trunk is good, they attain the sitting position to maintain the sitting position. So it can be used in even sideline position, not necessary to in a sitting. So now we'll see what are the stretching technique we use in PNF. So most commonly used in PNF is hold relax, contract relax, rhythmic rotation. So hold relax, we have a direct method and indirect method. Even contract relax, we have a direct method and indirect method. What is the difference between a direct method and indirect method for hold relax? So hold relax, what is the definition of hold relax? The hold relax name itself says that attain that position for some time and then after time relax. So that is the hold and then the relax. So that means the same muscle will contract, the same muscle will relax. So here the principal neurophysiology behind it is autogenic inhibition. So after some time, whenever G2 acts, same muscle will contract, same muscle will relax. That is nothing but a hold relax. So direct hold relax is that if suppose if hamstring is tight, we want to stretch the hamstring. So we have to give the resistance to the hamstring only, stay there, attain the hamstring position, and then after some time, same muscle will relax. If you want to again same, the main goal is to reduce the tightness of hamstring muscle. If it is using an indirect method of hold relax, we have to activate a quadriceps. So quadriceps muscle will contract after some time, the quadriceps muscle will relax. So in indirect, the main aim is to stretch the hamstring muscle, but we have to target in indirect quadriceps muscle. Again, contract relax, the movement will happen. We give a time to movement will happen. So here contract after some time relax. So movement will be there. So again, same direct or indirect, like a hold relax only. So direct when like hamstring is tight, if you want to use a contract relax method, then directly hit on the hamstring muscle. If indirect method, then activate the quadricep muscle. So here the movement is allowed in contract relax, but in hold relax there is no movement allowed. Attain the same position, and here contract relax, the reciprocal inhibition. The whenever there is a muscle is active, sometimes the other muscle has to relax. Rhythmic rotation. The rhythmic rotation says that when any movement we do in a rotation, muscle get confused, the tone get confused. So if for a temporary period of time, so when muscle fibers get confused that which movement we have to perform, so for that, for some period of time, the muscle get relaxed and we know that yes, the muscle length is improved. So these are the stretching technique we use. So now we'll see what are the videos of.
Push, 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 push. Good, push, relax.
Okay, so I was giving resistance to the hamstring muscle. I told him to push me down, push me down, push me down. And after some time, the same muscle get relaxed. And then you have to take up. So that is a hold relax direct technique. So here, what is the principle is autogenic inhibition. So whenever we give a resistance, the G2 will get activated and the same muscle contract after some time, same muscle get relaxed. We will see the range is increased. Now we'll see rhythmic rotation. Okay, so when we perform rhythmic rotation, we have to continuously rotate for some minute, for like few minutes, 1 to 2 minutes, and after that time suddenly you have to take up and lengthen the position. So rhythmic rotation helps to improve the range of movement when it is given in a fast manner in a rotation rhythmically. It again helps to improve the range of the muscle. So this was the all the technique and pattern we have discussed for the upper limb, lower limb pattern, and the what are the different types of techniques, which are the facilitatory techniques, which are the stabilizing techniques, and which are the stretching techniques. So these are the technique according or need of the patient we have to use, accompanies with the basic process we have to follow and a principle we have to follow. So we'll see what are the uses of PNF. So PNF, as we already discussed, that it has a wide varieties of uses. The uses is increase the strength, improve the flexibility, improve coordination, and yes, to improve the functional mobility in the individual. To facilitate the patient in achieving a movement or posture. To attain any posture, we use different types of technique. Yeah, so next is here diagonal exercise pattern. Stretches improve ideal functional mobility. Mostly we do all the activity in a functional movement, in a diagonal movement. So PNF most focus on the diagonal pattern, and with this the technique. So PNF is a wide variety of uses of the PNF. So now we'll see what are the recent studies. So recent studies on PNF, there is a studies done in 2018 by Ivana et al. So study topic was effect of PNF technique on increase in functional activities in patient after an incomplete spinal cord injury, a case report. So they found a positive effect by using a PNF technique, and they improve the functional ability in a spinal cord injury patient. So the PNF is a good tool to use, a technique to use to improve the strength even in a spinal cord injury patient. So next study the effect of PNF on standing balance control among the post-stroke patient. So this study is done 2020 by Hardin et al. And they found significant improvement toward the standing balance of the stroke patient. And here they use mostly stability, rhythmic stabilization, and stabilizing reversal in a standing position, and they found very good result. So next study, again, they done on the trunk, effect of trunk, proprioceptive neuromuscular facilitation on dynamic balance, mobility, quality of life in Parkinson patient. So trunk PNF they used to train, and yeah, they found improvement in dynamic balance, even quality of life in Parkinson stage of 1.5 to 3 on modified on annual scale, and they could administrate all the standardizing rehabilitation protocol when they use the PNF. So these were the recent advances. So at the end, in the summary, we have saw what are the pattern, upper limb, lower limb. Then we have saw what are the techniques, and now we have saw what are the recent advances. Thank you so much. Over to you, Dr. Nair.
Thank you, sir, for such an informative session. But in view of the recent advances, I would like to ask a question that which technique, which PNF technique would we prefer in patients with Parkinson's disease?
Okay, so good question. So in Parkinson patient, we have to see what are the major problem in Parkinson patient. So in Parkinson patient, major problem is a mobility. They have a problem in mobility. It's very difficult for them to easily move. So they hesitate while turning, while doing a movement. So here in a technique, most important technique here, we use a rhythmic initiation. So rhythmic initiation we use by using a PNF pattern also, in a pattern, so that they improve their mobility. So if they improve their mobility, so they easy for them to do the activity, easy for them to do the movement. So in Parkinson patient, the best technique is used is rhythmic initiation to improve their mobility.
Okay. Thank you so much, sir. Thank you so much, sir. It was a very enlightening session with great information about PNF. With the recent advances that you mentioned, have definitely illuminated how clinical practitioners can include newer literature and skill in treatment of patient care for better results. I would like to give a vote of thanks. Thank you, Executive Director Manisha Sangvi ma'am. Thank you, Chairman of I would like to give vote of thanks to Executive Director Manisha Sangvi ma'am. Thank you, Chairman of Sancheti Group, Dr. Parag Sancheti sir. Thank you to our beloved Principal, Dr. Apurva Shimpi sir. Thank you to the technical team and Dr. Tushar sir for our constant support. And I'll also like to thank all my viewers. Thank you.
Thank you.